So I would like to thank the organizing committee for having me. I feel quite exalted to be up here amongst all the academic illuminati. The talk I have to give is a little intense than the one you just heard about the billing codes. And I have no disclosures except the fact that my wife drew the cartoons and my son did the PowerPoint, because I am a complete trog. I'm not going to confine my talk to just low back pain, but just back pain in general. So I'll just move through these quickly. Back pain has been around probably since we stood up. There are x-rays from hominids showing extensive degenerative joint and disc disease. So I thought I'd quickly run you through how back pain has been looked at through history. So the first mention of back pain in Western medicine was in the Edwin Smith Papyrus at 1500 BC. It was only a fragment, and it didn't outline any treatment for back pain at that time, but common treatment was hot oil and massage therapy. About 400 BC, Hippocrates et al., and Hippocrates was not, the writings were not of just one physician, they were of several schools. He described ischial pain. Now, ischios is the Greek word for the hip. So sciatica is derived from ischios. And he described it as generally occurring in 40 to 60-year-old males, which would have been old for the time, and generally resolving in 4 to 6 weeks. He is reputed to have said that walking is man's best medicine. Moving forward to the Roman Empire, the most famous physician and probably the most influential physician ever to write was Galen. And Galen, you all have heard of the four humors, but what you might not know was that he was the physician to the Emperor Marcus Aurelius, who you might have seen if you saw the movie Gladiator with Russell Crowe. It didn't show the physician in there, but it did show some of the potions that he made up. And Marcus Aurelius tended to be a bit depressed, and he treated him with St. John's wort. He also looked after the gladiators. Sometimes they had absolutely horrible injuries, which he had to sew up, but he treated their spinal conditions with manipulation and massage, etc. His teachings dominated medical thinking for about 1,200 years. He is also reported to have said that that the physician is but nature's assistant. With the fall of the Roman Empire, the Dark Ages descended on Europe, and all of medicine became folkloric. And back pain was referred to as the witch's shot, or the shot of the elf. But I won't go into the treatments. With the rise in power of the Middle East, the Greco-Roman teachings were taken to the centers, particularly in Baghdad, where there was a large university. Two famous physicians you might have heard of. One would be Rhazes, and the other is Avicenna. Now, in Persian, that is Ibn Sina. And Ibn Sina is the second most influential medical writer in history. He was a very stern and demanding teacher. He had his pupils came from all over the West and the East. He had a very tough rural practicum for the students, in that they had to go out and investigate any abnormal events in the surrounding area. But unfortunately, plague was rampant at that time, so many of them never came back. The first medical examinations recorded were done in Baghdad around this time, because the caliphs one of the caliph's relatives had a bad outcome to a medical treatment and decided that physicians should be subject to examination. Hospitals were started, as we know them today, were started at that time, and they became specific to different types of diseases, which were looked at in a rational fashion. The food was really good in the hospitals. Anyone could come to the hospital. You could not be turned away because of race or religion, and treatment was free, mind you. It was a very wealthy society because they had a full domination of the spice trade. With the fall of Islam and the rise of power in Europe, Jewish physicians translated the Arabic texts and brought them back to the European centers. The first book that was written on sciatica was written by an Italian anatomist called Domenico Cantogno, and his main interest was the circulation of the CSF, and he thought that sciatica was caused by an excess of CSF pressing on the sciatic nerve. Now, he wasn't too far off, but he was famous for some of his experiments in that he would take a cadaver, stand it on its feet, lop off the head, and check for the CSF dripping out. I think he might have had a lot of fresh product, but I don't know. And if we move on to 1866, which was the time of the development of the railway as a mode of transportation, Ericsson coined the phrase railway spine. Now, there were an awful lot of bad accidents on the railway, but railway spine was thought to be caused as a result of the vibration of the carriages and caused a concussion of the spinal fluid and the spine. There was a lot of medical legal activity surrounding this diagnosis, and it eventually fell out of favor, but not before it was extremely well treated by the physicians of the time, who generously administered laudanum, and laudanum is a tincture of opium, I'm sure many of you know. Röntgen discovered X-rays in 1895, and from then on, back pain was attributed to abnormalities on X-ray findings. In World War I and World War II, due to the trauma, back pain became the domain of orthopedic surgeons and was treated solely with rest. In 1932, Mixter and Barr, one neurosurgeon, one orthopod, did the first operation for a herniated disc. And following this, all back pain was attributed to disc dysfunction. So this gave rise to an enormous increase in surgery. Two other professions that have dealt with back pain. 1874, Dr. Andrew Still, who was an MD in Kansas City, one of the reasons he is thought to have started osteopathy was because he was horrified by the indiscriminate prescription of narcotics by physicians, which resulted in his brother becoming very badly addicted. And in 1895, D.D. Palmer started the profession of chiropractic when he noticed that after adjusting a woman's neck, her hearing returned, and he felt that a lot of medical conditions were due to subluxations of the vertebra. Now back to today, what is causing back pain? And you can see the cartoon. What is causing my back pain, doc? And you can see what the doctor is thinking. I mean, you know, and it's true. You know, the pain generator is not known in over 85% of the patients that come in your office. It's just not known. So you can't just tell patients that. That's not going to work. So I tell them that it's a mechanical disturbance of the musculoskeletal system. It's a disturbance of muscle, ligament, joint, nerve, and disc. I tell them the spine is like an orchestra. Not everything is playing in tune. I reassure them that less than 1% is due to serious spinal disease, and that less than 5% is truly a pinched nerve or root pain. Now, having said that, a quick word on red flag issues. You all know them, but the only red flag issue that you have to be aware of in practical terms is a past history of malignancy, and particularly in women who've had a mastectomy. 20 years down the road, sometimes you'll get a woman in who feels perfectly well but just has back pain that doesn't go away. You have to have your spidey senses about you when you hear that. So they do require a little extra caution. Common back pain myths, and you may get a kick out of some of these. Tall people do not get more back pain than short people. Fat people do not get more back pain than thin people. Fit people get the same amount of back pain as unfit people, but they may recover faster. Leg length discrepancy has never been proven to cause back pain, and heel lifts have been very disappointing. There is a weak association between back pain and smoking. Alcohol, for any of you who might be really worried, is not a risk factor. Improved ergonomic setup and active rehabilitation programs, there's really a lack of measurable evidence to say that they significantly improve back pain. But obviously, many of you will have patients that they have. Weight loss is not a treatment for back pain. Doesn't improve it. Weight loss is only a very, very minor benefit to people with knee pain, despite all our best admonitions. Back pain is about the same in patients who sit in front of the computer versus manual laborers. So sitting in front of the computer all day long is not good for a back. Some special circumstances. Children under 15, very rarely do they require any treatment. If they do, normal type treatment, which I'll go into later, is fine. More than 15, surprisingly enough, teenagers have the same incidence of back pain as adults. It may be because they're growing or sitting in class all day or overdoing it with exercises and competitive teams, but the incidence is about the same. A couple of things I bring to your note. You have to think of in males, just to be aware of ankylosing spondylitis if they're not getting better. Usually they're very stiff in the morning, and they'll have pain in one of the other areas of the sacroiliac joint, usually. X-raying them really is not any good at all. It takes years for any X-ray signs to appear. Reasonable things to do would be an anti-inflammatory, or would be an inflammatory marker such as CRP, or a bone scan, even allowing for the radiation. An MRI scan, of course, is much more helpful, but not available generally. In female adolescents, you really have to check for scoliosis, because patients with scoliosis have more self-reports of back pain than patients without scoliosis. And you have to get them to bend over, and you have to be able to see the rib hump or the abnormality in the shape of the spine. Stress fractures, I see lots of those. Acute spondylolisthesis, they're usually competitive gymnasts, nearly all of them. The treatment's the same for any stress fracture. Pilates-based exercises are particularly good for either of these conditions, but particularly for scoliosis. Back pain in pregnancy, it's extraordinarily common. I see 2 or 3 patients every day with back pain in pregnancy. It's obvious, it's just a change in body posture with an increase in the lordosis and also an increase in ligamentous laxity. Uncomplicated pregnancy cases can be treated by all the normal methods such as physiotherapy, massage therapy, manipulation, or acupuncture. For patients who have localized pain in the area of the SI joint or in the pubic area, an SI belt is useful. For patients who tend to have more generalized back pain, the lumbar support belt that goes over their neck and comes around, people seem to find more comfortable. A quick word on whiplash. Females account for at least twice, at least if not more, patients than injuries than males. And despite your best treatment, 30% of them remain symptomatic at the end of a year. 30%, that's a lot, right? If they get pregnant, these ladies, following a motor vehicle accident, they're going to have an ugly pregnancy. Their breastfeeding is not going to be good, and the care for the infant is going to be difficult, and they'll have to get family members to help them. and if you have to deliver them, you may require help. The one thing that is associated for certain more than anything else with a prolonged recovery period from a whiplash is a pre-existing history of psychological dysfunction. Now that doesn't apply to whiplash, it applies to hip operations. If patients are depressed before they have a hip operation, their outcome is worse, but certainly in whiplash it's significant. Anyone who deals with whiplash injuries, and I'm sure you see them all the time, you should read the article by Gargan and Bannister from the British Journal of Bone and Joint Surgery, 2009. It's available at the College Library. Another good article is Carroll et al., 2008. All of these are available, but you don't really need to know anything too much about whiplash outcome once you've looked at, especially Gargan and Bannister. Some special circumstances in regards to low back pain. Spinal stenosis. The clinical findings are often very confusing. If you know your patients, then you know that their exercise tolerance is decreasing. Who needs surgery? Generally speaking, it's obvious if they can only walk 2 blocks and they have to bend over or get a shopping cart and bend over it to get some relief, then they need surgery. However, other cases in which people like to be active and out and about, and now their exercise tolerance is significantly reduced, they should really be referred, they should have a CAT scan, and they should be investigated and referred appropriately. In Lionsgate Hospital, it's daycare surgery for most spinal stenosis now, daycare surgery. The outcomes are generally very good. For patients who cannot tolerate surgery or who don't want surgery, a trial of 3 epidural injections is worthwhile. 1 injection every 2 weeks. Hip arthritis is a common cause of back pain in older patients. Generally speaking, however, hip arthritis causes pain in the groin. And the clue is they generally get pain when they're getting out of the car or they're getting up from a chair. If they have pain, then often you have to look at the hip. So you have to examine the hip and make sure that they don't have a significant loss of internal rotation. Just having arthritis of the hip, of course, can also cause generalized low back pain. Reasonable to send them to the radiology department, ask them to just do an intra-articular injection of local anesthetic and see if it improves their pain. Then you have an idea that maybe the hip joint is the main player here. It's not specific, but it may help the orthopedic or spine surgeon make a decision. You also have to think of compression fractures. If the pain is bad, it really doesn't matter how much the vertebra is compressed, but if they're not tolerating the pain well, then they should be referred for consideration of a vertebroplasty. Again, it's another daycare outpatient treatment. In seniors, you always have to think of myeloma and metastases. Now, this special circumstances, okay? P or poo. P being the most important and is forward in this drawing. Patients who come in your office with acute back pain, and you'll probably only see 1 in a lifetime, but if you work in a drop-in clinic, you may see quite a few more, and if you work in the emergency, you'll probably see a number of them. Patients who have acute back pain and are incontinent of urine. Incontinence is the commonest thing. You don't need to be testing the perineal sensation in those. They have to go straight to the emergency. All back pain is associated with some difficulty peeing. People say, oh, I can't pee properly, but incontinence or urinary retention is an emergency and has to be sent right away. In acutely herniated lumbar disc, this is one situation you need to act on. A younger patient with severe root pain and a definite motor deficit should have a CT scan or an MRI, preferably, within a week. If you get the radiology report back that says the disc is herniated into the foramen, then they need an urgent consultation, because in younger people, the disc is hard. It's not hard on someone like me. It's more like cheese. You could scoop it out, but it's a hard disc. It won't resolve, and it will cause damage to the nerve. So any neurosurgeon, I think, would be happy to see a patient like this. Otherwise, acute disc herniation can be treated depending on whether you're a rock star or a regular patient. Rock stars, including all medical specialists, go for surgery because the outcome is the same at a year whether you have surgery or not. But they're not ones to sit around being snowed on, dilaudid for 3 months and unable to work and torment their partners. They'll always go for surgery. But you can reassure the other patients that don't want to do this, the outcome is exactly the same whether you have surgery or not. Some strange symptoms that come from the spine, headache, occipitofrontal temporal, facial tingling. I see patients with that all the time that are at the computer for long hours, and it's probably related to tension in the neck and referred around to the face. Pain in the ear and jaw, obviously similar. But if you are working in the clinic and a young child, say 7 or 8, comes in with a pain in the ear, and you look in there and you see absolutely nothing wrong with the ear, make sure you just feel the TM joint, because they may have bitten down on something hard. And if that's normal, you should always just check behind, lie them down and just put your finger on roughly in the area of the C2 facet. And if they're very tender there, then you should refer them off to the physio, really. It'll get better on its own, but it'll speed it up. Eyelid twitching is a very common symptom from patients who have a lot of neck pain, muscle tension, chronic myofascial pain. Can certainly be helped lots by taking a holiday or getting suitable treatment. Anterior chest wall pain is extremely common. It occurs, a lot of patients go to the emergency with it. They have to have cardiac and other etiologies ruled out, but it's often due to a cervical or to a thoracic facet joint dysfunction. Pain in the testicles does not have to come from a herniated disc. It can actually be referred from the sacroiliac joint. I see a lot of patients in my office who are referred to me by obstetricians for groin pain and have had laparoscopies with nothing. And if you treat their sacroiliac joints and low backs, often this pain improves. Activities associated with back pain, running is bad for back pain. Patients with back pain shouldn't run. Moving, people who move their children or their grandparents, they're in the office all the time with back pain. In males, home renovations, building retaining walls, and weekend warriors, they're the ones I see. And in females, especially from the month of March on, gardening is the biggest offender. Ladies love to spend hours in the garden, pulling out weeds and digging, and it's sometimes cold and wet. So I see a lot of those. Dogs, big dogs pull ladies' upper backs and strain them. They sometimes have to be lifted into the back of a van, and they don't want to go. Small dogs run around them, and the ladies trip over the leashes. Back pain without root symptoms, I'll start with don'ts. Don't x-ray them unless you suspect a compression or a stress fracture. The findings of degenerative joint and disc disease are probably totally unrelated to what is causing their pain. And it's a pain in the butt for me to have to explain this to every patient that comes to see me with an x-ray, because I explain to them that their hair is different at 16 than it is at 60, and so are their x-rays. There's a weak association between degenerative disc disease in 1 or 2 levels and back pain, and a slightly stronger association if there are multiple levels, but it's only an association, it's not a causation. Try not to do CT scans on younger patients. I know this is just a generalization and you may have to, but just be aware of it. When you fill out the requisition, please put in what you feel may be wrong with the patient. It drives the radiologist insane. Back pain, x-ray lumbar spine. It leads to medical legal activities. You don't want it. Back pain without root symptoms, there's reasonable evidence, and the best evidence is for a multidisciplinary clinic. Like I told you, back pain is a blend of injuries. It needs a blend of treatment. The more heads you have working on it, the better. Reasonable evidence for treating back pain: physiotherapy, massage therapy, manipulation, and acupuncture. I have found IMS in our clinic to be particularly helpful to patients who are resistant to some of the other types of treatment. Acute medications for acute back pain, anti-inflammatories, of course. There's good evidence for the use of anti-inflammatories. Don't keep them on them too long. There's lots of side effects from them, and they may have a negative effect on cartilage. Very important point. Muscle relaxants are very useful and should be prescribed, in my opinion, for the treatment of acute back pain. Sleep is one of the most important ways of curing any pain, and patients who are able to sleep do have a huge improvement in their need to take a medication. They don't need half as much medication if they get to sleep. If you prescribe Flexeril or cyclobenzaprine, whatever you do, don't write a prescription for one tablet 3 times a day. It just snows patients. They won't take it, they won't like it, but it actually works quite well if you limit it to half a tablet in the evening and then build it up very slowly. But even at the best of times, it's hard to take it during the day. For chronic pain, if it's not too severe, I always recommend a trial of IMS. I find it very helpful for patients who are sitting in front of the computer. If it's severe pain, I always recommend a referral to a psychologist just to help them to cope with the pain. There are lots of good studies to support that. Antidepressants and antiepileptics are beneficial, but it's small. Just don't expect anything huge from them, but they can be helpful. Other things that are done commonly, facet and nerve root blocks, Botox particularly for neck pain and headaches, and Prolotherapy has its proponents. For some reason, antibiotics have been shown to reduce back pain in patients who are taking it for other reasons. Maybe they have anti-inflammatory properties. And I mention oxygen injections just for fun because there was a big article in the Vancouver Sun a couple of weeks ago about a new study that's being run at the spine clinic in VGH, looking at injecting oxygen into the discs. Now, many things have been injected into the discs over the past. We'll just have to see. If you have to prescribe opioids, and I know you all know this, you have to know your patients. It's really important. Up to 40% of prescribed opioids end up on the street. It's an enormous problem for the police, emergency health services, and emergency physicians. One dilaudid tablet can fetch $40 on the street, $40. So my final thoughts on treating back pain, I tell them all, motion is lotion. If they keep moving, generally the back pain will resolve. And for those of you who get fed up of listening to people complain about their back pain, I would bring to your attention Dominique Larrey. Dominique Larrey was the most famous physician in France at his time. He was Napoleon's personal physician. When Napoleon went to war and invaded Russia, during one of the battles, Larrey is reputed to have done over 200 amputations in a 24-hour period. Now, it wasn't the volume of work that is thought to have got him down, it may have been the flies. So I'll now pass you on to Dalen, who will give you a brief talk on IMS treatment.
Thank you, Dr. Quirke, for covering 2,500 years in 20 minutes. And for clarification, I'm Dalen, not Galen. I'm a modern day, or physiotherapist to modern day gladiators of golfers and office workers. Wanted to talk just briefly on intramuscular stimulation. Just a quick overview. And for the sake of time, I'll just move through some of these slides quickly, but it's commonly referred to as IMS. The definition is defined as a system for diagnosis and treatment of chronic myofascial pain. It utilizes a form of dry needling to identify deep contracted muscle bands or knots which have resulted generally from neuropathy, it's believed. The origin is not acupuncture, although it borrows from its origin. Many of you will be familiar with Dr. Chan Gun, and the origin of IMS actually lies here in Vancouver in the 1970s with his work at the Workers' Compensation Board. And it followed 20 years of observation and research, which helped him to develop IMS as an extremely successful treatment for chronic myofascial neuropathic pain conditions. And he's defined in using the term neuropathic or neuropathy as involving the peripheral nervous system, just for clarity. The model of IMS, based on a number of principles. The first is that of the work of Cannon and Rosenbluth back in the 1940s. I believe Cannon was at Harvard at the time, in which they stated that neuropathy causes end organs to become more sensitive and tender. And in this case, we're seeing it noted or manifested in muscles. The second of neuropathy, partial peripheral nerve restriction, again, and we're not talking about, as Dr. Quirke said, diagnostically visible level of these changes per se in causing deep, hard neurosigns, but they do seem to result in constant hyperactivity in the muscles, resulting in muscle shortening, tender muscle banding, as well as subtle autonomic changes on examination. The most common cause, again alluding to that point there on neuropathy, seems to be some of the changes that are taking place in and around the spine. Treatment through examination, affected spine segments and their corresponding myotome muscles are identified. And then the needle is used as part of the diagnosis and treatment. And it's done by distinguishing the responses between the two. So an affected muscle with an irritable nerve innervation to it will result in a very distinctive grasping sensation. This is felt by the patient, but also through the restriction or the tightening around the needle as you attempt to move it. That triggers a tendon reflex to relax or lengthen the muscle. And a normal muscle, on the other hand, has no response, and because of the size of the acupuncture type needle, the patient generally doesn't feel anything. The results can be dramatic, with immediate reduction in pain, increased movement and function, and in the cases where needed, the effect of the weekly treatments seem to be cumulative. And we typically find that emphasizing the downtraining of a hyperactive nervous system through IMS, followed by a resumption in activity or exercise, seems to work rather well. Indications in general, the appropriate referrals for IMS really include all of those chronic musculoskeletal patients that you don't seem to know what else you can provide. There's no specific ongoing injury, and they're often tissue non-specific. These patients have tried various forms of treatment already, and any investigations, x-rays, CT scans, are generally unremarkable, or at least rule out any more invasive approaches. Patient tolerance to this form of needling can be a consideration, but in my experience, nearly all are willing to try it, following appropriate education and considering their desperateness to find an answer to their pain, or in Dr. Quirke's case, whenever his golf game seems to suffer. As he mentioned, posture or repeated patterns of movement over time and the micro-tissue breakdown often results in chronic neck and low back pain. Conditions that are often indicated, I've given a list here, but just taking example of the WOD 2 or motor vehicle whiplash, treating the upper fibers of trapezius and C5-6 paraspinals can often provide a very significant change to their neck mobility and pain. I'll skip through a couple of these. Just some of the contraindications, they're really just a few, and they touch on infection or bleeding disorders. Although there have not been any reported cases of infection as a result of IMS, it is one of the contraindications that we have. Just a few cautions as well, and again, these slides will be available to you. But of course, we can't treat them all or fix them all. You got to be kidding, your back still hurts after all of that. There are no IMS cartoons that I've found yet out there, so I borrowed that. And for those of you interested in further information, either in research and in training, it is open to physicians and physiotherapists, and it has now been transferred from ISTOP, the Institute and Study of Treatment of Pain from Dr. Gunn, over to the UBC Faculty of Medicine, Sports Medicine Division. And here are just a few other websites where you can get some of this information. Thank you very much.